I do have the handout online, but it's all there, so you don't have to worry about taking copious notes. I'm going to be highlighting the information just in case you don't have the handout with you. And the first thing we're going to talk about today is this. It's a model I developed. Once again, it's on the handout, and the model is called the PI model. There's basically three elements to engaging, to communicating with patients. The first one is psychosocial, which is the bedside manner part. The second part is interviewing. That's where we get information from patients. And the third part is educating, giving information. And that's what we're going to be talking about the rest of this session. What I just did now is actually a powerful communication technique called signposting. And what signposting is, it's giving direction. When you go out on the street, you'll see these posts, and the posts have a sign on them. And what those signs give us is direction. They tell us where we're going. That's what patients want. In terms of patient satisfaction, patients want to know what's going to happen next. For example, if you're working with a patient, simply saying to them, first we're going to have a discussion about what brought you in, then I'm going to do a physical exam, then we're going to talk about treatment. That's signposting, and that's rated very highly by patients. To give you an example, I coach physicians, and there's a hospitalist group I'm working with now, and when I was done working that day, I did the valet parking, and I'm waiting for my car, and there's a lady there, and we started chatting, and she said her daughter's been in the emergency department for about 5 hours that day, but she was happy with everything, and I said, well, tell me what made the experience positive for you. Why was the experience good for you? She said, well, what I liked is they would always keep us up to date. They would say, okay, in another 15 minutes, we're going to have this result. Another 20 minutes, we're going to have this result. In another half hour, we're going to have this result. What they did is they kept her up to date. She wasn't sitting there for 3 hours with no updates, because that's what kills it with patient satisfaction. Most patients know when they go to the emergency department, they're going to wait. But they have to be updated as to what's happening next. What we're going to talk about now is the psychosocial dimension in terms of the PI model. And I've got a picture that illustrates that. And it's basically shoes. When you think of empathy, think of shoes. What is it like to temporarily be in their shoes? And the thing is, we don't want to wear their shoes, because if we wear their shoes and internalize their issues, that's what leads to burnout. So we just want to temporarily step in, see what it's like, see what they're experiencing, and then step out. So whenever I'm working with patients, I always think, what is it like to be in their shoes? What are they experiencing on a psychosocial level? And I've got an example here that I'll read off to you. It's in the handout, but I'll read it off to you. And what you're going to have to do will just take 10 seconds, 15 seconds. You just need to talk to someone next to you. Patient came in, and think about, after I tell you what the patient said, think about what are they feeling? What's the feeling? What are they experiencing? If you wanted to complete this sentence, sounds like you're feeling, or this must be very, this is the scenario. Work has been a challenge because of my stomach problems. I'm always running to the bathroom. It's a constant struggle. Work has been a challenge. It's a constant struggle. I'm always running to the bathroom. How is that person feeling? What was that? Anxious, stressed, frustrated, overwhelmed, flatulent. I guess that's true. They're feeling flatulent. Embarrassed? You had something? Okay, yeah. All those, the flatulence, that's, that could go either way. But what happens a lot when I work with physicians, and I keep in mind, we're people in healthcare, we're very high cognitive. We're thinking, what tests do I order? What treatment do I plan for this person? Well, the patients are just the opposite. Unless they're in healthcare, they're high emotional. They don't know if we're ordering the right test or listening to heart sounds appropriately. Everything is emotional for them. It's all based on emotion. And what happens, a lot of the physicians I worked with, since of course we're so high cognitive, there was one physician I was coaching the patient, he was a gentleman, he was close to 80. He was talking about his wife had passed away 2 months ago. He was literally on the verge of tears. On the verge of tears, he says, you know, my wife died 2 months ago. She handled all my pills and all my appointments, and she did all that for me, and now it's really hard for me. And then the physician then said, how long have you been having that pain in your belly? She completely missed the emotional dimension. And I could see by the look on his face, you know, you just missed it. And that's when we get dinged on the surveys that the doctor didn't care about me. They didn't care about me. It's missing that emotional element. And the thing is, you probably think, well, you know, how critical is that? Well, what they find is there is a relationship between empathy and outcomes, because once people feel comfortable, they're more likely to share, and they're more likely to follow our advice. How about this example? I just had a breast biopsy. The results are not in yet. I'm so scared I have cancer. How's that person feeling? Anxious? Frightened? Fearful? Yeah, those are all, of course, appropriate things to say, but it's important that we address it. It's important that we address it. I know this is very frightening for you. I know this is very scary for you. And I've worked with a lot of physicians that has been said, and the person went right back to, you know, how long have you had the pain? Is it worse on the right, worse on the left? Completely missed the emotional element. And the thing is, that's when patients feel they don't care about me. So that's why whenever I'm listening to patients, I'm always listening, you know, stress, anxious, you know, what's going on. And I find, for lack of a better word, stressful always works, because often people in the healthcare system, unless they're going for some kind of wellness check, there's always some stress involved. Now, what I always try to do with that psychosocial element, I try to, if possible, I try to inspire people. And one of the things that I talk with people about is a deck of cards. I said in life, we don't necessarily get the hand we want, we get the hand we're dealt. But we do have choices of how we could play the hand. And I think about this in terms of everyday life. I travel frequently, and I had an actual experience right here in South Carolina at the Columbia Airport. Flying to Columbia, get to the airport, I'm in the baggage area, waiting for my bags. Half hour goes by, 2 bags are going round and round. Neither one of those bags is mine. I talked to the people from the airline. I said, have you seen my bags? She said, let me do some checking. She says, we found your bags. Oh, great, great. They're in Atlanta. I said, but I'm in Columbia, South Carolina. So, in thinking of the deck of cards, that was the hand that life was dealt to me. And I do have some choices. I mean, I could scream and yell, is that going to get my bags back? No. So I think about the other options. I thought, well, I'm just going to go with it and enjoy it. And I decided I was going to make this a positive experience. So I was trying to figure out how am I going to make this a positive experience. And how I found this to be a positive experience, they said, in case your bags don't get here tonight, we're going to give you a bag of toiletries to get you through the evening. This is where I found the positive experience. In that little bag of toiletries, this was the size of the deodorant. I told a lady from the airline, I said, I am a 6'3" man. This is not going to give me that fresh feeling. So I thought, I only have one of these and I want to use this in my program. I better get another one. So next time I was at the airline about a month later, I said, you know that little bag of toiletries, can I buy one of those bags? I'd love to have one of those. They said, no, we don't actually sell them, but I'll just give you one. I said, oh, great, I'll have a little backup deodorant. Well, it looks like somebody heard me speak because they made the deodorant a little bigger. Now it's this size. It's a little bit bigger, a little bit bigger. But the point of that story is when I talk to patients, whatever illness they're dealt with, whatever disease, this wasn't the hand they wanted. This was the hand they were dealt. So what's the best way we could play the hand? So when I talk to patients, I talk about, here are the options. This is the hand that life dealt you. This is the hand that life dealt you. And there's different ways that we could play this hand. And then I talk about some of the productive ways. Some of the productive ways, the productive treatments, and how to follow those treatments. So it's an inspirational element I try to add on to my patient discussions. Now, we talked about the psychosocial, which is basically empathic communication. But when I interview patients, and I've interviewed hundreds, probably thousands by now, many patients said they want their physician and other healthcare professionals to say something to them. They said they want directly to have this stated. They want their physician to say, I care about you. And I've told that to some physicians in coaching, and they say, I know, it sounds a little hokey. Just, you say, I care about you. Does it sound a little hokey? But I'll try it. And they've said that to patients who maybe there were some compliance issues, and they said, I care about you. You know, I want you to feel better. And then many physicians have called me up afterwards, and they said, you know, they were actually compliant after I said it. I couldn't believe it. They said, oh, I mean, they were so taken back when the physician said, you know, I care about you. I want you to feel better. Let's talk about getting this medication in your life. And it had a huge impact. Just those few words had a huge impact. So it's empathic communication and making statements like, I care about you. Now that takes care of the P in the PI model. Now we're going to talk about the I. And actually, the most critical parts of the interview is not the middle part, it's actually the beginning and the ending. Because people tend to remember beginnings and endings. That's why if you ever go to a concert, they always have a big, exciting opening. Because they want to capture our attention, get us excited about being there. And they also have a big closing, because you have to have a good closing so we reflect positively on the whole experience. Now, I'm sure all of you have seen pharma commercials on TV. All pharma commercials follow the exact same format if you look very closely. When do they mention all the nasty side effects like, you know, sudden death? Right in the middle, because that's where people tend to forget things. But they remember the beginning, they remember the opening, like you see this man, he's sitting there, he's sad, and then he's dancing in the next scene, and then at the end he's dancing again, but in the middle, that's where they put the side effects. So we have to have a very strong opening, and we have to have a very strong closing. And one of the things that I always do is I always, of course, first say the patient's name, and I always start with a more formal approach with patients. And once you get to know them, maybe you could use a first name basis. The one thing that's come up with a lot of interviews, most patients are okay with this, but a small minority of patients don't like certain nicknames like honey and sweetie. More and more patients are telling me they don't like that. And I talked to one patient, she was telling me her doctor is about 20 years younger than her. She went in to see him, and he said to her, how are you doing today, young lady? She was not very happy with that. Actually, I don't quite understand why she wasn't unhappy. When people call me young man, I'm thrilled. I remember I was at a Wendy's, and I got an iced tea, and the lady said, here's your iced tea, young man. I was just beaming. I was thrilled. I said to her, thank you so much for calling me young man. And then she said to me, I used to work at a retirement community. We called all the old guys young men. So, okay, thank you. Thanks for sharing. And some other things is, of course, always meet the family members, because keep in mind, in terms of patient satisfaction, if your patient is debilitated in some way, maybe there's dementia, they've had a stroke, when that patient satisfaction survey comes, the family members might be the one who are filling it out. So that's why it's important that we connect with the family members. So what I do is, after meeting the patient, make sure you meet the family members. And what I try to do if a patient is very, cognitively aware, I say to the patient, I see you have some guests, would you mind introducing me? Because what they'll do is they'll give the relationship. They'll say, this is Carol, my daughter. This is Bob, my husband. Because if you meet the family members, sometimes what they'll do is they'll say, hi, I'm Bob. And you don't know the relationship. So that's why, if possible, try to get the patient to introduce me to their family members. And a few other things is I start with depending on the situation, I start with an open-ended question, tell me what brings you here today. And then what I do is, after they tell me their chief complaint, I recommend not really getting into it yet, because there might be something else going on, and we call that the oh, by the way topics. And that's at the end of the interview, you think you're in good shape, you've got everything down, everything looks good, and then the patient says, oh, by the way. And then they bring in something totally new, and you're about ready to wrap up. So I found 2 words that physicians have told me this changed the way they practice medicine. 2 words. What I recommend, this is based on the literature, is after you do the chief complaint, tell me what brings you here today. Instead of going into that in detail, use these 2 words. Anything else. Anything else. And you might be able to find things that would have come up at the end, and now you could immediately address them. I've had patients that I've talked to when coaching physicians who came in with something that was pretty mild, wasn't too major, and then the physician said, anything else? And then the patient casually mentioned, well, actually, for the past 2 months, I've had rectal bleeding. What? He may have not even mentioned that. So that's why this anything else, it catches those things that we may have missed earlier. In terms of the closing, I always recommend closing with something like this. Some kind of partnership statement. Because a lot of times when I coach physicians, they often close, well, feel better, take care. Those are the kinds of things you say if you see someone at a grocery store that you haven't seen in a while. You say, well, take care. If they've been maybe under the weather, you say, feel better. It's too casual for a therapeutic relationship with a healthcare provider, a physician. So I tried to close with some kind of partnership statement, such as, I know this is happening to you, but we'll face it together. Or a friend of mine, Paulette, one of the patients that I interviewed, I told her, I asked her about her experience being diagnosed with colorectal cancer. I said, tell me about the experience. Tell me what made the experience powerful for you in terms of your interaction with your GI doctor. And she said, well, after I came to from the sedatives, my GI doctor was standing there, and he was holding a photograph of the tumor, explaining to me what's going on. Then what he did is he took my hand, and he said, I will be with you every step of the way. She said, that made all the difference for me. And what is that? That's a partnership statement. Some statement indicating that I'll be with you. It could be, I'll be with you every step of the way. I know this is happening to you, but we'll face it together. That's very powerful in terms of the patient experience, knowing that we're working as a team. And for example, the hospitalist group I'm working with now, because with hospitalists, patients could see a different hospitalist each day. So one thing I recommend they say at the end, the other physicians and I will be with you every step of the way. And it's important that we say that at the end, because remember, patients tend to remember beginnings and they tend to remember endings. So we have to have a very powerful ending, because people remember what happens at the end. That's why we have to have a very powerful ending, and that's where these partnership statements come in. And a few other things I wanted to talk about now is about some nonverbal communication. And I've got a picture here. Before I say anything, tell me, what looks good about this picture? What is this clinician doing well? Sitting. Looking in the eyes. Smiling. Pardon me? White coat is clean, yes. White coat is clean. Yeah, those are all the great things. She's sitting, eye to eye. The ideal is something called squaring up. Squaring up, like for example, if Gary was my patient, squaring up is eye to eye, shoulder to shoulder. It's like there's a square between the two of you. That's the ideal situation. They did a recent study at the University of Kansas. What they did is they recorded 120 patient-physician interviews. Now these 120 interviews, they were all approximately the same amount of time. With 60 people, the clinician was sitting. With the other 60 people, the clinician was standing. Then they asked the patient, how long was the physician with you? What they found is, with the physicians that were sitting, the patients estimated the time to be double. So their perception when we sit is that we're with them much longer than we may actually be. Now, in many of the physicians I coach, some of the problems we run into, especially in a hospital situation. You walk in and there are family members sitting there, they have their stuff on the chairs, so sometimes it could be a challenge, but oftentimes there's a chair in the corner, and I always recommend pull up that chair and grab a seat, because that makes a difference in terms of patient satisfaction. And if worse comes to worse, and there's no chair available, leaning against a windowsill, just not standing directly, because that, in terms of patient satisfaction, has a very negative impact. And once again, it may be a challenge sometime to find a chair, but it's highly recommended because this has obviously a very dramatic impact, just the act of sitting. And another thing in terms of interviewing is avoid interrupting too soon. There's a classic study of tape recordings of physician interviews, and they wanted to determine how long the patient talked before the physician interrupted. Anyone have any guesses what the average length of time before the physician interrupted? You got 5 seconds, 30, 10. Actually, you're in the ballpark. This is the actual number. It's about 18 to 23 seconds. And most patients are barely off the runway in 18 to 23 seconds. So what the literature recommends is you ask your question, tell me what brings you here today, and then think of the remote control you have for your TV set. What's the button you press when you don't want any sound? Mute. Mute. So think about the remote control you have inside of you. Ask the question, what brings you here today? Tell me what's going on. Then hit your mute button and let them talk. Because oftentimes in my coaching physicians, say a patient comes in, their chief complaint, chest pains. Well, tell me what brings you here today. Well, I had this pain over here. Is it worse? Worse on the right, worse on the left? What about when you stand? What about you sit? They just completely miss. So once again, just let them talk. And also what I recommend at the closing, a lot of times physicians that I work with, at the closing they'll say, do you have any questions? And most patients will say, no. When I take my mother to some of her visits, they always say, do you have any questions? My mother always says, no. No. Do you have any questions? Do you understand everything? My mother always says, yes, yes. We're driving home. This is what always happens. My mother says, I didn't understand anything. I didn't understand anything, but you're in healthcare, you could explain it to me. Now the thing is, I could explain it to my mother, but what if I wasn't there to explain it? And one other question to avoid during interviews is questions starting with the word why. Why questions are very accusatory. A physician once said to my mother, she wears the support stockings for some edema issues. Why did you stop wearing your stockings? My mother became very defensive about that. Why did you stop taking your medication? Well, there's one clinician I worked with. The patient actually was having some significant issues for several days and waited about 3 days to go to the hospital. Now, he asked the patient, why didn't you come to the hospital sooner? And the patient became defensive. Well, this was going on. What's another way that we could find out the reason that patient did not come to the hospital sooner without using the word why? What are some other questions we could ask without using the word why?
What made you think and decide that you needed to come today?
Right. That's exactly. I replace the what with the whys. Replace what with whys, because think about in your own life. Somebody says to you, yeah. Oh, I meant replace the what's why instead of what's. What's instead of whys. What's instead of whys. There I go. What's instead of whys. But think about why questions in your own life. Like, why didn't you pick up the laundry? Why is this room so messy? Why questions are very accusatory, and patients get very defensive. So instead of saying, why didn't you take your medication? What was going on that prevented you from taking your medication? It's a much more patient-friendly way to speak. Now we're going to talk briefly about educating, and this is one of my favorite things from the literature. It's called chunk and check. Instead of giving them a ton of information and then asking, do you have any questions? What the literature recommends is something called chunk and check. And the reason I show a tape measure is because one of my friends, Kate, she has a genetic disorder that predisposed her to cancer, and she's been diagnosed with cancer 6 times. She's had colon cancer 3 times, ovarian cancer, uterine cancer, and breast cancer. And I said to Kate, how do you cope with all of this? And she said, this is how I cope with it. Yard by yard, life is hard. Inch by inch, life is a cinch. She says, you just have to take it inch by inch. So when I'm working with patients, I'll say to them, everything feels like this right now. What we need to do is we need to back it up, and we're just going to take it inch by inch, piece by piece. And I find, in working with patients, I find that dramatically reduces their stress level, just taking it piece by piece. That's how they're able to cope. Also, one other thing is I talk about avoiding medical jargon. All the physicians I coach, they always tell me, I never use medical jargon with patients. I would never use medical jargon. And there's one patient came in, had some heart issues, cardiac issues, and she was reviewing the results with the patient, and she said to the patient, your cardiac enzymes are negative. What's a plain English way to say that? Right. Your heart tests are normal. Your heart tests are normal. And I actually had one physician, and as soon as he said it, he immediately looked at me because he knew he did a little blunder. He said to the patient, have you recently had an ischemic event? And then he looked at me like, oops, I know that wasn't good. Actually, I came across speaking of medical terms, I came across a store. I live in the Ohio area, and as soon as I saw the store, I had to take a picture of it because obviously with this store, the person is not in the healthcare field. This is a store I came across recently. So I had to see how they answered the phone, so I called them up and they said, hello, the stool store went, I had a lady come up to me after a program when I was speaking at a hospital. She works in the pathology department. She says, when you showed the story, that picture of the stool store, I have to tell you, a few years ago we had a man came to the pathology department and he brought his stool specimen in an, I can't believe it's not butter container. To this day, I can't use that product. But once again, the critical thing to remember is think about plain English, because like I said, I have a lot of people that say, I never use medical jargon. I never use medical jargon, but the thing is, that's the language we speak with each other, and sometimes we forget. Patients might not necessarily know what that means. And also in terms of educating, one of the things I highly recommend is providing resources. For example, one of the health things I have going on is I know I do this, I drink too much diet soda. I drink a lot of Diet Coke. Sometimes I could drink a whole 2-liter. And my wife tells me, you know, drinking diet soda is bad. You have to quit. You know, I already know that. Like with patients who smoke, I would say, your patients who are smokers, I would say they probably know smoking is bad for them, and they probably know they should quit. I mean, that's not a news flash for them. So it's saying, you need to quit smoking. You need to quit smoking, it's bad for you. Just like most people know they shouldn't be eating a lot of high-fat foods, but they still eat it. So what we need to do is we need to give them resources, tools, and one of the tools that I found with the Diet Coke is a tool I've learned just to replace. So I'm just replacing water instead of having the Diet Coke. Giving resources. There was one physician I was working with, the patient was a smoker, and she said to the patient, you have got to stop smoking. Got to stop smoking. I think the patient already knows that. And this was in a hospital situation, and I said to the physician, are you aware that this hospital has a smoking cessation program? She wasn't aware of that. I said, that's what would make the difference. So next time, and you know ahead someone has a smoking issue, print off from the website the one page about the smoking cessation and give them that, because they need tools, they need resources. That's what's critical. And what I also do with patients is I do something called teach back. And what teach back is, this is really when you've given them a lot of information and you want to see, do they really know this? Do they really get this? But you don't want to just say to a patient, okay, repeat back what I just said. Repeat back what I just said. I do it in kind of a sneaky manner. What I'll do is I'll say to a patient, I know I've given you a lot of information over here, and I just want to make sure we're on the same path. How about if you explain it back to me? Or another thing that I've done, I'll say to the patient, say I'm talking to the gentleman and the wife's at home, I'll say, when you get back home, what are you going to tell your wife your treatment plan is? So this way I'll get an idea, did they really get it? Because a lot of times if we just say, do you have any questions, do you understand it? They'll appear like they understood it, and I've read multiple studies, like recently with diabetes, where they went through the traditional diabetes education and they said, do you have any questions? Then another group went through the education and then they did the teach back. They found out there was dramatically higher compliance in the teach back. So speaking of teach back, what I'd like to do in the moments we have remaining is thinking about what's the best thing you got out of this session. The best thing you got out of the session. And I always like to hear what people have to say. And the way that I get a chance to hear what people have to say, I do a little toss game. And I do a lot of programs in GI, and the Fleets Enema people actually have this little mascot called Eneman. See, it's got a little enema tip right here. I had the Fleets people introduce me, and I actually had the 6-foot-tall Eneman introduce me. So what I'm going to do is I'm going to toss this in the air, and if you catch it and you feel comfortable, just think the first thing comes to your head. Best idea you got out of this session. How about if I toss it over here?
There were a lot of things that you said that rang true from my personal experience. So it was a reaffirmation, I would say.
Validation. Anything in particular comes to mind?
The discussion of why versus what.
Okay, not using the accusatory whys. Okay. Okay, who?
Because for a long time I used to begin my history with, what made you decide today that you had to come to see me for your child? And that's a very open-ended question. I mean, it doesn't say, what made you decide fever was
Right.
your problem or anything like that, or seizures or whatever. What made you decide this morning was different and you had to come see me?
Okay, not using the accusatory why. Okay, who would you like to toss it to?
Catch the bouquet.
Okay, best idea.
Like I said, I didn't get the full program, but when Todd instead of asking people what brings you here today, I like to ask them, what can I help you with today?
Okay, what can I help you with? Okay, another version. Okay. Okay, great. Who would you like to toss it to?
Well, another comment I have is that I find it interesting that we're actually teaching bedside manner and what I once thought was common to physicians, that they had thought about this to begin with before even entering the profession, because of the concern for patients and the therapeutic relationship of the physician-patient relationship, which is now almost becoming a thing of the past, and we're having to reintroduce doctors to what it means to be a physician, which I think is good but also sad in a way, that medicine has become such basically a commodity, a commercial transaction. You're like the clerk at the grocery store, just ringing them up. And this is great, all this is wonderful. One problem is finding the time to do all that under the current practice conditions.
Yeah, what I find it.
Speaking from a primary care.
Yeah, what I find is a lot of physicians I've coached have said this to me, I don't have time to do this. And what I find, it could be very quick. Sounds like this is, stressful for you, using what instead of why. I find just these, so it's not often adding time, it's just changing, tweaking current things.
The point is, it shouldn't be quick, and you're more inclined to engender a therapeutic relationship if you have the time to sit down with your patient. I used to sit on the bed with them, that kind of stuff.
Yeah, and even sitting for a few minutes, the impression is you've been there a while. Okay, great. Well, who would you like to toss it to?
Ironic.
Oh, okay.
I like the, excuse me, the interviewing, the opening in the middle you were talking about, where it's less stressful for the patient, and in the end, leave it a good ending.
Right, because people remember beginnings and endings, absolutely. Okay, we'll do one more and then we're done.
If I'm ever caught in an airport and lose my luggage, just pick up one of those bags that's still rotating around. That would be better.
Okay, take somebody else's bag?
No, when I went to medical school and one of my professors was here, we were taught that if you listen long enough, the patient will tell you what's wrong with them.
Right. No interrupting. Okay. Okay, great. And in the few seconds we have remaining, I always like to close with a few dog pictures. Here's a picture. I caught one of our pugs walking on the counter. First she was very excited until she saw me, and then this was her expression. And then one of our pugs, this is her. She was a bridesmaid at a pug wedding. There she is. She's just beaming. And this is a greeting card with another pug, Miles. Friend of mine, after he got this card, he called me up and he said, "You and Beth look good, but the baby's ugly." Then we caught one of our pugs, Chica, sitting in a flower pot. And what I love about this is the quote, "Bloom where you're planted." And that's something I instill in everyone. I always, when I talk to younger people, I always say, no matter where you are in life, wherever you're planted in life, you need to bloom and grow and prosper. And I always like to close with this quote. Life is not about waiting for the storm to pass. It's about learning to dance in the rain. Many of the patients we work with have chronic illnesses. They'll always have that storm. They'll always have that rain. But one of the things that we could do is help them cope and help bring them joy and help them cope with that experience. Thank you again for listening, and I wish each one of you all the best. Thanks again.